now I request Radhika ji to make her presentation. She's the founder, managing trustee of AASTHA. Over to you, Radhika ji.
Um, when the COVID-19 disaster struck, there was a question that came in front of many of us. Where are all the people with disabilities? How do we reach out to them and other vulnerable groups in our country? What are the kinds of services, habilitation and rehabilitation services that should already have been put in place if we are to reach out, and if people with disabilities and people living with long-term illnesses, for example, are not to slide back after there has been the huge disruption to our lives. In order to understand this, AASTHA and IFRA embarked on a 1.5-year-long study where we studied 5 community-based organizations in 4 states of India. AASTHA working with migrant populations in Delhi, Ishwar Sankalp in West Bengal, working with persons with psychosocial disability on the streets of Kolkata, Jan Swasthya Sahyog in Chhattisgarh, a public health organization working in remote tribal villages, working with people with non-communicable diseases such as diabetes, sickle cell anemia, cancer, high blood pressure, TB. Sadhana in Odisha, working again in the rural and tribal areas of Odisha, and a cross-disability organization. Sanchar, another cross-disability organization in West Bengal, working in the 24 Paraganas on the outskirts of the city. In these organizations and through these organizations, we spoke to 114 people, their caregivers, families, and as well as community workers, as well as the management and the teams of the organizations. We found that most people, in fact, all except for one, were in the informal sector. They were earning their living. Majority of the group earned less than 10,000 rupees a month. That is less than $125 a month. Most of the persons with disabilities that we spoke to had dropped out of school due to inaccessible environments, and more than half the persons with disabilities were not married. They lived in very inaccessible environments. For example, a person living in a rural tribal area in Odisha had to cycle 25 kilometers just in order to get a packet of medication. Or in Chhattisgarh, where the remote villages are only connected to the city with one bus that travels daily. As we talked to people and asked them what were the challenges that they faced in actually their functioning and in participation, they spoke about all the challenges and the intersection of these challenges with the social and environmental factors that affect their lives. The one thing that came out very clearly in our interactions and interviews was a picture of exclusion and discrimination. 81% people spoke about discrimination and exclusion, not only in their interpersonal lives, but also at the institutional level. The other thing that struck us very strongly was the fact that whatever be the limitation in functioning and participation that a person is facing, the mental health aspect of it, the emotional aspect of it is very, very big. The mental and physical aspects of participation and functioning are intricately linked, and that is very important when we are talking about how rehabilitation services should be structured in any country. So, for example, people spoke about feeling of sadness, irritability, restlessness, of constant living with constant tiredness, of pain, of mobility difficulties across all groups, whether they be people with psychosocial disabilities or whether they be people living with tuberculosis and cancer. difficulties in communication. These were some of the big things that came out when we spoke to people about what kinds of barriers they were facing. And then there were specific groups, for example, women. Women had to continue their gender roles even if they were ill and tired and on long-term medication. For some women, marriage was not an option. The elderly with their reduced ability to work and independence and exclusion from the younger members of the family were often facing a great deal of loneliness. As we looked at the organizations and how they worked with these people, we understood the range of strategies that were similar while each worked in their own way. These included, firstly, building trust, a proactive outreach, reaching out to people, going to their homes and in the community rather than expecting them to come to them. A rigorous follow-up, because rehabilitation is a process and not a one-time thing. Person-centric care, sharing knowledge about the condition and how to deal with it so that people can become self-sufficient and independent. Building groups and networks so that people who are largely often isolated can become connected and learn to act together to look out for their rights. A multidisciplinary and a multi-stakeholder approach to rehabilitation where inclusion into various institutions is prioritized. Access to entitlements and influencing change in communities and social change by focusing on inclusion and looking at all the determinants of health and the other factors that affect inclusion. One of the most important strategies here was the community-based workers. And I'll talk about them, people from the community who worked through the organization with and for people with disabilities and those who lived with long-term illnesses. And then Corona struck. And with Corona, people spoke about the most important things that they spoke about was not only did they lose the meager income and tumbled further into poverty, but the lack of food and the diversity of food. For example, water was not available on the streets of Kolkata for those who were homeless, or salt was not available in Chhattisgarh, or vegetables. In Delhi, there was absolutely people who lived from day to day had no food in their homes. This resulted in increased stress in their families, an increase in the feelings of sadness and helplessness, increased fear and anxiety for people who were already living with these conditions and emotions. But despite these huge losses that people faced, people were able to respond to the crisis and they were able to continue the care because of the strategies that had already been used with them. Support groups and networks that were already in place were activated, and organizations of people with disabilities, groups of people living with long-term illnesses, mothers group were able to organize food, money, shelter, psychosocial support, and connect with relief work. The building and strengthening of community where people were able to reach out to each other and new leaders emerged. The strategy of the organizations to increase knowledge and on self-care and promotion and self-reliance, the involvement of the family, and the focused inclusion in society strengthened the pandemic response for people who would otherwise have been very isolated, and they knew what to do in this situation. Linkages that were already made with official institutions such as health services, education services, government programs. These linkages that had already been made promoted pandemic preparedness and response by the people. Basic needs that were not being met at that point were ensured for all: food, shelter, medication that many people needed. The services also continue
Radhika ji, you have a
therapy,
minute.
counseling. Okay.
You have one.
All right. All these were able to continue despite the fact that there was such huge loss. The CBR workers were at the center of this. They were not only the first responders, but they were also the people in the community who became the first responders during the crisis. Our recommendations here are that countries must invest in a universal design of rehabilitation services where rehabilitation services are available for a large number of people, and yet the specific requirements of people with disabilities, people with high support needs, people living with long-term illnesses, and others are taken care of. We recommend the need for comprehensive rehabilitation care closer to where people stay because it is a process and not a one-time thing. The importance of mental health care being integrated with these services has come out strongly like never before after this disaster. The need for proactive outreach, since persons with disabilities and people with long-term illnesses will not come constantly to the services. So it is important for this service to reach out to them. The significance of context-driven strategies, understanding the unique needs of poverty, disability, and illness, that intersection in organizing our services. The importance of institutionalizing this cadre of community-based workers who are really our first responders in most instances. The importance of strengthening the support structures, networks, organizations of people with disabilities, caregiver groups of people with living with different illness so that they can become active during such times. The importance of inclusion of vulnerable groups in disaster preparedness and response. And of course, the state being our largest provider in a way, synergy with the state during disasters. Thank you very much.